Okay, it looks like we are at the top of the hour, so we're going to go ahead and get started because we are jam-packed with information. Good afternoon, everyone, and thank you for joining us today. We're going to go ahead and get started with, it's my great pleasure to welcome you to our third and final webinar installment on essential steps for navigating the tumor-infiltrating lymphocyte TIL journey in melanoma, looking at common obstacles, logistical considerations, multidisciplinary approaches, and best practices throughout the journey of TIL therapy. So before we begin, I have a few reminders. Please use the Zoom question and answer to ask any questions. They'll definitely be answered towards the end of the webinar. You can utilize the vote function within this section to move questions up in the queue. Please do not put any questions for the faculty in the chat. This video will be available to view via the ONS webpage in the coming days, as well as via HOPA's YouTube channel. Now, for our HOPA viewers looking to claim credit, make sure to write down the unique CE session code at the end of the session in order to submit for CE credit in HOPA Learn. And then this course should already be on your dashboard within the HOPA Learn platform. None of the planners or faculty for this activity have any relevant financial relationships with ineligible companies to disclose. And for the Oncology Nursing Society, this is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Learners who view the full webinar and complete the online evaluation will earn 1.0 NCPD contact hours. The link to the evaluation will be provided in the chat at the conclusion of our time together, and the evaluation will be live for 2 weeks following today's program. This webinar is being provided jointly by ONS and HOPA, and so I'm very, very excited. It is my pleasure to introduce today's panelists. Andrea Fadel is a transplant and cellular therapy nurse coordinator at the University of Chicago Medicine. Dr. Rebecca Gonzalez is a board-certified pharmacist in oncology who currently practices as a clinical pharmacy specialist in blood and marrow transplant and cellular immunotherapy at Moffitt in Tampa, Florida. Oh, Eugene, I should have asked you how to pronounce your last name before I got here. I apologize in advance. But Eugene, who currently serves as a clinical pharmacy specialist at Roswell Park Comprehensive Cancer Center in Buffalo, New York, serving patients afflicted with lymphoma, leukemia, and multiple myeloma. I owe you one, Eugene. I apologize. And last but not least, Lauren Walford is a case management nurse in Nebraska Medicine specializing in BMT, CAR-T, and cell therapy. I'll now hand it over to the panelists and looking forward to a really great discussion.
Thanks for that introduction, Zahra. We can go ahead and get started. Some of our objectives for today: one, to discuss common obstacles and barriers for onboarding patients of tumor-infiltrate lymphocyte therapy. Two, evaluate logistical concerns for coordination of care for TIL therapy. Three, illustrate multidisciplinary approaches for maintaining the TIL course. And four, review supportive care measures and best practices post-TIL infusion. So I will get us started by going into a little bit of background information on tumor-infiltrating lymphocyte or TIL therapy. So for those who may not be familiar, TILs occur naturally in a patient's tumor as their own lymphocytes recognize their tumor cells as abnormal and penetrate the tumor. In TIL therapy, that tumor is resected. Those TILs are isolated and expanded before ultimately being reinfused back to the patient. TIL clinical trials have been underway for many years, but our first commercially available product was approved earlier this year by the FDA under accelerated approval. And I will hand it off to Andrea to get into a little bit more about this commercial product.
Thank you, Lauren. So lifileucel, or Amtagvi, was FDA approved this year in February for the treatment of adult patients with unresectable or metastatic melanoma who have been previously treated with a PD-1 blocking antibody and BRAF-positive BRAF or MEK targeted agents, specifically if they have a BRAF V600 mutation. This indication was approved under accelerated approval based on objective response rate, which means that continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials.
So this approval of lifileucel has expanded access to TIL to more institutions across the country, which has gotten us started with this conversation on some potential challenges to incorporating this therapy. So TIL does fit into the cellular therapy landscape, which has historically been focused on hematologic malignancies. So this can lead to some challenge integrating a cellular therapy process into the workflow for solid tumor care, as well as coordinating with those departments who may not be familiar with the regulations of a cellular therapy process. The commercial product also has a portal, which we'll talk a little bit more about in the coming slides, but this is used for scheduling and documentation. So this also requires some thoughtful integration when thinking about working this into your program. Staff education must also be considered throughout this process, including outpatient and inpatient care teams, lab, infusion staff, and pharmacy, not only about each of their steps in the process, but also how they can work together to create a streamlined workflow.
So when we think of a patient's journey through TILs, first thing is, of course, that we are identifying who would be considered a good candidate. After that, and we get all this insurance approval, we do a bunch of testing. The big first step is that tumor tissue procurement, or that surgical resection, which does take some extra coordination, like Lauren was mentioning. From there, we ship those cells off to the TIL manufacturer. And when they have completed manufacturing this product, they'll ship them back to the site before we start lymphodepleting chemotherapy for 7 days, and then infusing those TIL cells. After that, we will start up to 6 doses of high-dose IL-2 administration, and this can start up to a couple hours after that those TIL cells are infused, up to 24 hours later. These IL-2 can be infused between 8 to 12 hours, so each institution will look a little different. From there, we're really just waiting for the patient to recover from those side effects from the lymphodepleting chemotherapy in terms of counts, but then also all the side effects from the high-dose IL-2, which we'll go into in more detail later. And from there, they are discharged back to the outpatient side.
So we will talk about some key things to consider during patient evaluation before getting into some specific evaluation testing on the coming slides. So when discussing patient eligibility, this should be a multidisciplinary approach between the surgeon performing the tissue procurement, the medical oncologist, and the cellular therapy physician. And they may look different per your institution's structure. Pharmacy should also be included early on in these discussions, not only to ensure IL-2 availability within your institution, but also to start some patient education with all the medications that happen in this process. So due to this multidisciplinary approach and these many teams that are involved, there should also be a clear plan for patient coordination during this time. For example, many institutions have a cellular therapy nurse coordinator who has experience with these type of products such as BMT or CAR-T and can kind of help guide these patients through this process. There should be a clear plan for patient communication at different checkpoints and when this care is transitioned between teams. So while the patient is undergoing this evaluation, it's also important to recognize some potential scheduling challenges. The goal here is to minimize the risk of significant disease progression prior to TIL administration. And the challenge can be finding a manufacturing slot in an appropriate time frame that also aligns with your institution's availability. So this is crucial to establish an efficient process of scheduling these procedures. So when a manufacturing slot is available, you can quickly schedule that procedure in your institution. Andrea, did you have any other thoughts in relation to patient selection?
No, I completely agree that one of the most critical relationships you'll form on the cell therapy side will be with your surgical team. It's definitely something unique that they have not encountered before, where they are not the ones in charge of the schedule, but it's something that eventually everyone can all be on board with. Other important parts, I think you nailed it. There's multiple groups involved, so just making sure you know who to reach out to and really forming those great relationships. Particularly this time of year, it's always important to send out those thank yous and really make sure everyone knows how much you appreciate the effort they've put in for these patients over the past year.
Absolutely.
So now that we've selected these patients, we need to evaluate them. So initial evaluations policies tended to be based off the clinical trial protocols with a combination of the existing institutional cellular therapy SOPs. There has been an article that I'm sure a lot of institutions are using to base their protocols or SOPs off of for TILs. That's particularly helpful in going through all the different areas we're looking at. We are, of course, considering cardiac function, doing echocardiograms and electrocardiograms. We are going to be doing a whole bunch of labs, right? Looking at CBCs. We're going to be checking renal function and liver function as well, and also those infectious disease markers. We are also going to be checking the disease. So we will need some sort of imaging to look at the melanoma, but it does depend on the location of the disease for which image in particular we might get. PETs might be preferred, but we might need CTs of a specific area. We also want to check for brain metastases as well. So following brain MRIs or head CTs based on the patient is pretty important. Another important aspect of this location of disease could also be considering if we need pulmonary function tests, if they're high risk where it's involved in their lungs, or just additional tests in general to see what, to look at safety for these patients. And this is a big part of the nurse coordinator's role. Besides the patient and caregiver education, we are really scheduling all of these tests and trying to make it as smooth as possible for these patients. As we mentioned earlier, we are coordinating with the surgery team for surgical assessments. I'm very fortunate to work with a wonderful surgical nurse associate. So and I highly recommend this, have at least bi-weekly meetings discussing upcoming patients and then also going over past patients so she feels like she gets that full clinical picture. Where the nurse coordination is also pretty important for insurance approval, especially as this is a newer product. Insurance companies may have specific requirements that might seem a little extra, but we do need to make sure that we have insurance approval before we start making any moves on this rather expensive treatment. And of course, as mentioned, that manufacturing slot selection is pretty crucial as well. Lauren, did you want to add anything about patient evaluation?
I think that was a very thorough overview. One note about insurance approvals, depending on the payer, there's a couple different ways that this procedure can be approved, whether it's as one lump procedure or the tumor procurement process and the cell therapy infusion separately. So I think just going through your process and policy, it's important to leave some wiggle room in there, just as payers are trying to still figure this out.
Absolutely. And we've got some other practical considerations, so other eligibility criteria. I did mention brain metastases earlier, and that's because there is a hemorrhage risk. So you want to make sure they're stabilized prior to TIL cell therapy. And if they do have it and it's stabilized, you might want to consider a higher platelet threshold. Retrospective data has shown some efficacy, but no real toxicity data. But some randomized control trials have shown some subarachnoid hemorrhage risks. We also want to be aware of hemorrhage risk for bowel mets as well, again, considering those platelets. Cardiac considerations, we're really concerned about the IL-2 associated complications, but the lymphodepleting chemotherapy could also pose some challenges. So if they do have some cardiac concerns, you might want to consider additional testing like a stress test or a cardiac consultation, especially if you have a cardiologist who specializes in oncology. Same goes for pulmonary. If they're a high-risk patient or if there's lung involvement, please do a pulmonary function test. And if they have some moderate or severe lung disease, work with your pulmonology team to see what sort of interventions we can do to make this as safe as possible. Of course, renal as well. Again, we're thinking about IL-2 toxicity, but also how are we dosing that lymphodepleting chemotherapy? So we want to make sure that GFR is greater than 40 and possibly get nephrology on board. Another consideration that's not listed on here, but is equally as important would be if a product is out of spec. So if a patient's TIL cells are made, but they don't quite meet those FDA indications of at least 7.5 billion, it would be considered out of spec. And at this point, you need to consider is how far out of spec it is. And does the physician want to move forward with using an out of spec product, potentially with an extended access program or with a slower single case IND? Does the patient have time to wait? Or do you need a recollect? And again, can the patient handle this additional wait time? So just really important things to think about when we're looking at these patients and these products.
Wow, you guys really blew it away out of the water there. Are there anything else that Eugene or Rebecca, you guys want to add in terms of patient eligibility considerations when you think through that?
I think one thing that comes to mind for our patient population being in Florida, we do have a lot of older patients. So certainly frailty, I think across all oncological disorders certainly is something to consider. These patients technically should be in the hospital for 2 weeks, but certainly a lot of patients may have challenges and need rehab or prehab before coming to TILs. So I think that can be a little bit more particularly challenging because they may have one or more organ systems that are affected, but certainly still can proceed. And again, kind of modifications to lymphodepletion chemotherapy, considerations for IL-2 certainly come to mind.
Absolutely. Eugene, I see you nodding. Anything you want to add there?
No, I think Becca did a really good job there explaining it. I think, every patient has a unique circumstance, and sometimes you do have to work through, some of the complications. Some of these eligibility criteria can be, modifiable, like we talked a little bit about increased platelet parameters and, maybe some patching up in other areas as well.
I agree. I would echo everything that both Andrea and Lauren really touched on. One thing that we've done here at my center is we've set up a separate weekly huddle with our melanoma and surgery teams that we didn't have when we first started the process. And so that was a learning that we had, that we needed to touch base a lot more frequently than we were, just to make sure that all of our logistics were sorted out. So with that, I think we'll switch it back to Lauren to keep us going, and we'll break in a few slides.
Yeah, I can lead us through some discussion about the actual tumor tissue procurement procedure. So we know that TIL products have been successfully manufactured using a variety of different sites. The current standards are that the operating surgeon resects approximately 1.5 to 4 centimeter diameter tumor, taking care to remove any fatty or necrotic tissue. After the tumor has been successfully removed, it's important to keep adequate chain of custody of the sample as it's placed into the sterile media before being packed and shipped. So this chain of custody is actually reflected using that online portal because it does require 2 staff members to sign off at each step in real time. So these steps include the media preparation, the media delivery to the OR, tumor specifics such as size, location of removal, time the specimen was placed into the media, and then packing and shipping specifics as well. So this does require you to identify which team members will be participating in each step of the process, since these teams will require training and access to document in the portal. So definitely something to consider as you're scheduling these procedures, which staff members you have trained and who you can dedicate to each step of this process. Another consideration is possible pathology confirmation of the tumor sample. While this is not a requirement of the commercial product, it may be requested by your physician team to confirm the status of that tissue before being sent for manufacturing. So considerations should be ensuring the tissue size is still acceptable for manufacturing after that piece of it is sent to pathology, and also the original sample stays sterile at all times. So after the tissue is sent for manufacturing, I'll hand it off to Eugene to now talk about disease control during that time.
Yeah, so ideally, by the time that they're ready for their TIL infusion, the disease has remained under control. However, I think realistically speaking, based on everyone else's experiences, we know that cellular therapies and transplants don't necessarily go as planned. In the initial trial, there was 14% of patients who did not receive a TIL after harvest, and 6 of them either had progressive disease or died. As Andrea pointed out on the previous bit of information, there were also 2 patients that did not receive TIL products, indicating that the manufacturing process isn't as clean and perfect as we would all hope to be. A key inclusion for the trial was a washout period of about 28 days or more. However, expanded access programs have allowed bridging therapy to be used. The time from the time that the sample was received by the drug company to the delivery back to the site is 22 days, indicating, roughly a 3-week period in which, the disease has to hold. So we know realistically that not all disease behaves nicely and kindly. And so those patients with high burden, rapid progression, or cancer-related organ impairment may need bridging therapy to help avoid toxicity and delays with TIL and IL-2 therapy.
And as Eugene mentioned, there is a significant importance on bridging therapy. Realistically, in clinical practice, although in the clinical trial it's about 22 days, realistically it can be a month total, 5 weeks. So really we want to try to stabilize these patients as best as possible so they are able to receive this therapy. I think one of the unique aspects for melanoma is we do have targeted therapy, BRAF and MEK inhibitors, in which do actually have some unique toxicities ranging from cardiotoxicity, skin toxicities, as well as hepatotoxicity. So there are some concerns in terms of how best to bridge therapy and when do we need to hold or temporarily withhold therapy prior to tumor extraction due to the risk of bleeding and hemorrhage that are associated with many of these agents. And then also overlapping toxicities with our lymphodepletion chemotherapy. What I can say is when initially we started off, we had a very conservative approach and trying to hold therapies for at least 7 half-lives of the drug. So our agents like Bini and encorafenib really actually have a short half-life, usually around 4 hours. So certainly kind of this week-long hold parameter we initially did just to kind of see to make sure to be a little bit more conservative. But I can tell you now in practice, we can hold it up to 24 hours before our harvest and our lymphodepletion. And our practitioners are actually considering potentially for those higher risk patients, continuing therapy through the TIL journey just to kind of maintain that disease control. Now, for those agents like trametinib, which maybe the half-life's 4 to 5 days, certainly having a longer time off therapy and washout period may be necessary to reduce toxicities. Many of our patients may get adjuvant radiation therapy or big classic chemotherapy like carbotaxol. And certainly there isn't like a fine number I could provide to you, but usually we want to wait for resolution of acute toxicities. And this may take up to 2 to 3 weeks to occur. So really a patient-specific, not a one-size-fits-all, and really having a joint discussion with the patient, the provider, and also the pharmacist on your team is critical. I'll turn it to Eugene, who will talk about some of the logistical challenges as we prepare to receive TIL.
Yeah, and so the actual, the meat and potatoes of the therapy is really broken down into 3 different phases. So, it's not just the TIL infusion. We have the lymphodepletion that precedes it. Sometimes this is done as an inpatient, and in other centers where there's more comfort and understanding, this can be done as an outpatient, the TIL infusion itself, and then IL-2, which is typically done as an inpatient. So our lymphodepleting regimen of choice in the trial was Flu/Cy. And, I think everyone's familiar with this from, CAR therapies. However, I do want to point out a few things here. First and foremost, the doses and the frequencies do change ever so slightly between products. And in particular, the cyclophosphamide is based on a milligram per kilogram basis in the trial. Along with high-dose cyclophosphamide, obviously comes the aggressive hydrations, and there are different ways to do that in practice, and there are going to be practice variations with that in mind. But, Mesna, at 0, 3, 6, and 9, or variations of that are also possible. Fludarabine given once a day for 5 days, of course, adjusting for renal function. I think, as you look at this regimen as a whole and in comparison to what we're doing with CAR T and, with IL-2 in mind for TILs, it's really important to have patients be euvolemic. So in the days post cyclophosphamide, making sure that they become euvolemic, that their weights have stabilized, their fluid status is okay, is an important consideration in that.
So I think one of the most exciting aspects of our TIL program is the ability to kind of adapt and utilize our experience from CAR T. So these patients are actually exposed to very similar lymphodepletion chemotherapy that our CAR T patients have. And so certainly many centers have experience with this. So we're able to kind of adapt and individualize patients' care through modifications of this chemotherapy. So one of the unique things that our institution, I'm sure a lot of other institutions are incorporating, is the ability to condense and stack chemotherapy. So patients are actually able to receive this lymphodepletion over a 5-day period versus a 7-day period. So really, this is a win-win for both the patient and the institution by limiting the number of days the patient remains in the hospital, as well as time at home. Another modification, very similarly to mirroring CAR T, is a modification specifically for renal impairment for fludarabine. So certainly there is an ability to actually reduce the dose depending on the degree of impairment. And then lastly, I think something that will evolve over time as many institutions incorporate TIL therapy is the ability to modify cyclophosphamide dose to hopefully mitigate some of those common toxicities that Andrea and Lauren talked about, cardiotoxicity, hemorrhagic cystitis. And so certainly in the literature, we actually have a few studies that investigated lowering the dose of cyclophosphamide from a total of 60 mg per kg each day to 30 mg per kg each day, so about a 50% reduction. And they actually saw similar efficacy with a reduction in toxicities and hospitalizations. So here at our facility, we actually incorporate a reduced flu-cy dose strategy, particularly for patients that were really worried that the patient's not going to tolerate full doses, those that actually have brain mets because of that risk of hemorrhagic bleeding events, as well as those patients that are a little bit older in age. And again, we live in Florida. So many of our patients actually receive this reduced dose strategy. And so some other opportunities that we can do in terms of lymphodepletion, and many of this kind of mimics our CAR T aspect on how we treat patients, is the ability to treat patients both in the outpatient and inpatient setting when undergoing lymphodepletion. So I know a lot of institutions kind of go back and forth on how best to administer lymphodepletion, and I think certainly this is a patient-specific approach. At Moffitt initially, our game plan was to give all patients flu-cy in the outpatient setting to really mirror our clinical trials in our CAR T program. However, for the first 10 patients, we actually admitted all patients to receive lymphodepletion inpatient. And really, we thought, these patients may need a little bit more TLC and closer follow-up, specifically in terms of fluid balance, just to make sure that we are maintaining, as Eugene said, that euvolemic state. So certainly there is an opportunity to transition these patients in an outpatient setting. A lot of institutions may also do transplant. So post-transplant cyclophosphamide also requires Mesna. And typically a patient will be in the outpatient setting for about 12 hours. So I just wanted to kind of see for everybody else, how are you all currently doing your lymphodepletion at your program?
Yeah, I think for us, we're looking at inpatient use. I think the hydration, the volume status is really important to us, and I think there is a degree of comfort that I think comes along with the experience. So I think we're a little bit more immature on that, and so I think preferring inpatient for now.
We are actually doing inpatient as well still. Same as those reasons, but also the care coordination aspect as well. It does require some more resources if you're keeping that patient outpatient, the case management during that process and any symptoms that may come up. So definitely something to think about. I think there are pros and cons to each option.
And we try to do all of our patients outpatient. However, some do go straight inpatient. Some people get admitted earlier due to side effects. And we are very fortunate to have some great patient assistance programs, because one of our biggest challenges would be finding housing for patients who are coming from pretty far away. So in Chicago, for the longest time, there was really no center within a 5-hour drive. I think St. Louis would have been the next closest center for TILs. So we had patients coming from Wisconsin and Iowa and Michigan and Indiana. So Oklahoma at one point. So we did, for those patients, we might consider more of an inpatient approach, but a lot of people also enjoy being outpatient and not staying those extra nights in a hospital bed with hospital food.
Yeah, and Becca, you bring up a really good point, as you do you, Andrea. I would say for the University of Kansas, just to add on our 2 cents, we universally are doing them outpatient. We, of course, reserve the opportunity if a patient does absolutely need to be admitted for flu-cy, but for the vast majority, and I think all of the ones that we've done have all been outpatient. We have it really well set up. We've got a really strong outpatient clinical program. So it's been easier for us. I think there are challenges, of course, with days of the week and how often or how long your clinic is open on the weekends. And so there are also a lot of, you just like the slide states, practical considerations when you think about it. I think everyone likes the idea of outpatient, but may not always be set up to do that right away. But certainly that is how we do it. And I will be honest, Becca, I didn't even think about dose reducing the lymphodepleting. We do full dose for everyone, and so that's something that I think I will certainly be taking back. So I appreciate you sharing that little tidbit. All right, Eugene, you want to
All
take us
right.
off?
Yeah. All right. Again, just to reiterate, lymphodepletion, the TILs, and then of course IL-2 come in within days of each other. And so, like when I'm teaching and talking about chemo, it's like a band playing a song. And so you start to think about, as you develop your ear, you can appreciate individual sounds and pick them up, kind of like the side effects and toxicities. So, there are going to be overlapping toxicities between IL-2 and lymphodepletion, and, kind of getting a sense of where each sound is coming from is really important. So I don't think that this list is particularly a surprise to anyone. Lymphodepletion is known, for myelosuppression, and so a change in blood counts is to be predicted from these therapies. Things like hypophosphatemia, leukopenia, fatigue, also really commonly associated with chemotherapy. But things like febrile neutropenia, hypotension, I think those do need to be parsed out and evaluated. Some of the symptoms associated with febrile neutropenia, including hypotension, potentially, could be complications of IL-2 therapy as well. So let's take a look more into adverse events related to lymphodepletion and IL-2 and how they're treated. All right. So backing up a little bit and going into supportive care, lymphodepleting chemotherapy, of course, it is chemotherapy, and so there are GI toxicities associated with it. Flu-cy is a moderately emetogenic regimen. However, due to the theoretical impairment of TILs, it is recommended to avoid steroids. So in terms of managing that, maybe instead of using steroids, you are using an NK1 antagonist, the serotonin receptor antagonist, and olanzapine as well. So a triple therapy just with no steroids. And then, using other agents to manage the other toxicities associated with nausea, vomiting. GU and renal toxicities is always a concern when we're using high-dose cyclophosphamide and you have renally adjusted chemo. And so, hydration with frequent bladder emptying is really important. And so, I think you're left with this balance between aggressive hydration for the sake of preventing hemorrhagic cystitis versus, obviously being euvolemic and having stable weights and no cardiovascular complications from overhydration. So use of furosemide is encouraged and can be helpful in managing the fluid status. As I referred to on the previous slide, cytopenias are also very common, and I think across the board we are using growth factors like filgrastims or equivalents basically at day 1. I know that that's what we were set up to do, and I know Becca had made comments that she does that as well. So I think doing that and continuing that through count recovery is really important. Now, count recovery is going to be different from each institution in terms of their parameters. And so, there is kind of an assessment you have to make based on your institutional standard and whether that needs to be changed for TILs. And the same goes true for red blood cells and platelets. So maintaining hemoglobin of 7 and platelet count of 30,000 is important as well. To reiterate, obviously the myelosuppression, obviously neutropenia, febrile neutropenia is also possible. And so anti-infective prophylaxis should be used. I think a good place to start for institutions is their own individual standards and deciding whether or not those need to be modified based on the patient population. The current product is indicated in melanoma where there isn't as much myelosuppressive chemo, where I think a lot of experience comes from CARs. Nonetheless, I think the myelosuppression is there, and so anti-infective prophylaxis is a good idea. So things like antiviral, antibiotic, antifungal prophylaxis is important, as well as PCP prophylaxis. The endpoints of these prophylactic strategies will vary depending on what we're preventing. But for things like antibiotics and antifungals, when count recovery is there, I think those can peel off. Things like antiviral and PCP, you're looking at CD4 counts plus a time frame somewhere between 6 and 12 months, and CD4 counts above 200. Now, I do want to reiterate that there are overlapping toxicities with IL-2 and infections. And so you do have to, be suspicious of infections while you're also suspicious of IL-2 toxicity. So, prophylactically, we do use antipyretics with IL-2 use. And so they can mask fevers, and, being aware of any temperatures pre-Tylenol might be really important. When you are looking at IL-2 toxicities, you should suspect and also consider workup for infectious complications, cultures, other markers. And then, any hypotension that's really unresponsive to fluids really does favor infection. Moving on into TILs themselves, I think that they're really interesting to talk about. I think overall the mechanism is a little bit more complicated in the sense that it lacks the specificity that we're used to in cellular therapies. These products are polyclonal, and they have diverse antigen specificity. So the TILs themselves are a mix of CD4 and CD8 cells. The antigens are not selected out like they are for CARs. And so you're left with, kind of a nice heterogeneous mix of antigens that are targeted. And that helps it overcome some of the immunosuppressive hurdles that we see with other therapies like regulatory T cells, other cytokines, in the hopes of inducing a response in the cancer itself. Now, the IL-2 does get added in, and this is something that actually is not as new or novel as we think it is. There was historical efficacy seen in the 1980s when they did use LAC or lymphokine activated killer cells plus IL-2. The IL-2 allows for the T cells to expand and grow and hopefully enhance the response.
Let's discuss some kind of general concepts in terms of creating kind of a checklist to really establish kind of the little components to tee up a patient when they're ready to receive their TIL product. First and foremost, to make sure that the patient actually has an available TIL. It's not out of spec. We don't have any issues with the actual product. We have it on hand. As toxicities that we discussed for both lymphodepletion, and in the future, we'll talk about some IL-2 related toxicities. We really want to ensure that a patient has adequate organ function. We don't have any abnormal lab values where we need to support or transfuse a patient. Many of these patients have received targeted therapies and immunotherapies prior to coming to TILs, so they actually may be on prednisone for physiologic dosing due to adrenal insufficiency. So certainly those patients that have a history of having kind of crises during a stressful situation, certainly incorporating some of our consultative services like our endocrinologist into the mix is really important. Kind of going back again, you'll hear this again, euvolemic. Fluid balance is really important. So we are very particular at weighing patients every single day to really ensure that these patients are at their baseline. And if not, we'll try to diurese them as the best as we possibly can. Many of these patients, especially with aggressive disease, may have other effusions, so paracentesis, thoracentesis, really to reduce the overall symptomatic presentation. Because once we actually start IL-2, it can actually exacerbate some of those symptoms. And then lastly, kind of focusing on the TIL readiness, we do want to make sure that patient has central access to receive not only the TIL product, IL-2, and any subsequent medications such as antimicrobials or pressor support, hopefully not, but just in case. And then we make sure that we actually are holding some medications that may worsen hypotension, like blood pressure medications, or if a patient has low platelets, hopefully holding some of those blood thinners as well. So looking at our overall practical considerations for the TIL infusion overall, if you want to go to the next slide, Lauren. One more back. The TIL product itself has a wide variety of cell dose. And for your patient, they may receive between 1 to 4 total bags of the TIL product. Now, typically this is administered within 1 to 4 days from the last dose of fludarabine, and really this is based on the package labeling. However, I can tell you this is a recommendation, but in certain cases where a patient's not hemodynamically stable enough to receive product, it is okay to delay until that patient is stable enough. So I think that's one worry we try to follow as pharmacists, like to the T, like it's, within 4 days. However, as a patient, the biggest thing for repeating lymphodepletion is that ALC. So as long as their ALC is low and their lymphocytes are declining, we don't need to reintroduce lymphodepletion chemotherapy. Now, this is a cell product, and patients are at risk for infusion-related reactions, so they do get very similar pre-medications to any other cellular product. I do want to point out for those that don't practice in CAR T or the transplant space, this product actually does contain DMSO. So some patients can actually have a DMSO reaction. So it's very rare, less than 5%, but just to be aware of it, that can happen. But the good news is this product is very well tolerated, and we don't have CRS and neurotoxicity to worry about. So that's great. So on the next slide, we just kind of want to discuss what is the role of IL-2. So actually, IL-2 in this setting actually plays 2 roles. Before the patient actually receives the TIL product, the patient's actual TIL or the tumor is resected, the TIL is isolated, and then actually exposed to IL-2. And essentially the role at this point is to actually stimulate growth and development of the TIL itself. So initially, the product or the TIL itself is expanded and grown through in vitro exposure to IL-2. And once that happens, the cells are amplified further during a rapid expansion protocol. And this allows these TIL products to expand into the billions. So once they expand, the product is ready to be, and this is why it may take up to a month to occur, because there's a lot of things and a lot of processes that are ongoing at the manufacturing level. Once a patient actually receives the TIL product itself, the patient is then exposed to a systemic level of high-dose IL-2. And essentially, again, kind of the idea there is to promote growth, expansion, and persistence of those TIL products. However, I do want to point out that the number of doses do not correlate to efficacy. So if a patient is hemodynamically unstable, can't tolerate IL-2 at all, it is okay not to receive. However, we do try to get at least 1 dose in, and I think that's kind of our checkbox and our gold star. Now, these patients can receive up to 6 doses. So for those that are tolerating it, we do try to get all 6 doses in. So there's some medications that we can help to kind of reduce overall toxicity that's associated with IL-2. And for those that practiced it back in the day when we utilized high-dose IL-2 for renal cell carcinoma, know the spectrum of toxicities that can occur, anywhere from fever, chill rigors, all the way to capillary leak. So it can go from 0 to 60 very quickly. So these patients are at risk for fevers, and certainly giving antipyretics like acetaminophen can be beneficial. And typically this is scheduled about 30 minutes before each IL-2 dose. Now, I mentioned capillary leak syndrome. So for those that are not familiar, this can occur actually due to prostaglandin release, which essentially makes the blood vessels a little more leaky and increases the permeability. So NSAIDs actually help to block that prostaglandin and limit the permeability of those cells. So hopefully we're limiting peripheral edema and those type of complications. And then as you mentioned earlier, of course, our lymphodepletion is associated with some GI toxicity and nausea and vomiting. So certainly we have the opportunity to continue those therapies. I do want to point out that typically, even if you stop IL-2, we usually try to give these supportive cares for at least 12 hours after the last dose of therapy. And I'll turn it back over. We'll go over to Eugene.
All right. Hi. All right, so for TILs, the goal is 600,000 units based on actual body weight every 8 to 12 hours for up to 6 doses. There is a little bit of a range here, and in the trials, patients received a median of 5.5 doses. So the majority of patients received the majority of the doses. Typically, the start time of IL-2 is about 3 to 24 hours post-infusion, and I think that that's part of the implementation strategy to consider once we get there. Again, to reiterate, the purpose is to kind of enhance the T cell activity and development. There are studies, and it has been used in the past, and things that I remember is that you can use TIL monotherapy for disease control, both in renal cell and in melanoma, so the data from the 90s. And to kind of reiterate that point, overall response rate in patients who did not receive any IL-2 in the trials was 29%. So it is definitely not something that is entirely required for some effect. In the interest of time, I think we did hit on the importance of maintaining good renal function and euvolemic state with daily weights and checking creatinine, avoiding nephrotoxins wherever possible. And also, I think one thing that is sort of new to this slide is talking about antihypertensives and, understanding that blood pressure is a little bit labile, potentially with IL-2 in patients who have toxicity. And so holding them wherever you have a little bit of room to do might be a good idea. So some practical considerations about IL-2 administration is, standardizing your approach to IL-2. You want to streamline operational aspects, your holding parameters, who's in charge of making the decision. So is it charge nurse, specialty nurses, attending physicians, pharmacists, making sure that that is consistent, that that's reproducible and reliable depending on weather, holidays, weekends, so on and so forth. And so you really want to limit their variability and really structure that. Another really good idea is to develop a good timeline where you're administering doses at specific times. And so that even probably begins from a TIL standpoint and understanding that the time frame begins around the time that TIL, so it's 3 to 24 hours post TIL infusion. So even timing that might be a benefit, and standardizing the schedule. There is some debate about whether you use 8 or 12 hours as your frequency. As Becca pointed out, there's no correlation between number of doses and efficacy, so there is some room to play around with it. And to Becca's point, I think we do consider re-challenging patients who are having issues, and getting a dose in and then just letting it be is also a good idea. Now, our center has defaulted to a Q12 hour frequency for our approach to IL-2. Lastly, I think one approach is to take, like we do with cytarabine, where you have to get neurochecks and then you get the approval for each dose rather than holding parameters, and to make it more of an active process in administering IL-2. In terms of monitoring recommendations, I think these are consistent with the TIL working group. So checking vitals and pulse ox every 4 hours, and then more frequently if patients are hemodynamically unstable. Things like telemetry through the post-TIL process or post-IL-2 process, strict I's and O's, basically through the entire process, understanding, we use a lot of fluids earlier in the lymphodepletion, daily weights, neurologic assessments as well.
And just briefly touching base, we kind of discussed overall of the common toxicities, but if you learn anything from this, majority of your patients will experience some sort of fever, chills, or rigors while undergoing IL-2. So certainly medications to support antipyretics, opiates for rigors certainly can be utilized in this case. Approximately a third of patients will experience hypotension, tachycardia, diarrhea, of which can be managed by supportive care, fluids, of course. One of the key things I do want to kind of point out is about a fourth of patients actually do experience more of those kind of scary toxicities from IL-2, including hypoxia and that capillary leak-like syndrome. So certainly these are the patients that you want to monitor very closely. And as Eugene mentioned, maybe pause, skip a dose, reassess, triage before reinstituting. And I think oxygen support certainly can be beneficial in those hypoxic patients. A lot of times it may actually be due to fluid overload. So certainly kind of balancing, is this related to the IL-2 itself, or are we just kind of having a patient that's a little bit more fluid overloaded? So on the next slide, I just kind of wanted to briefly talk about kind of the importance of establishing an institutional criteria as far as slow go versus no go. So really determining those relative and absolute criteria for administration of IL-2. And this is definitely a collaborative approach with your oncologists, the medical team that's on the service, really to determine when are you not comfortable with proceeding with IL-2. So certainly on the left-hand side, there's several different organ systems that can be affected by IL-2. And certainly I think some of them that we typically have very low thresholds to stop is when patients are experiencing significant pulmonary toxicity requiring oxygen support. So at this time, typically patients who require maybe 1 to 2 liters of oxygen more fall within the relative criteria, whereas those maybe requiring 4 to 5 liters, that's where we kind of may pause a little bit and decide maybe we won't continue this IL-2 course. IL-2 is renally cleared. So for those patients that go into acute renal failure, you're not able to process the medication and certainly at a higher risk of toxicity. So this would be also kind of something where we may have a little bit pause in a group discussion. So I'll transition it back to Eugene, we can kind of discuss a little bit more of the IL-2 aspects.
Yeah, I think the previous slide is really important in assessing when and where to hold and when you need to. I really like the slow go versus no go approach. That's a really good. It's a throwback to CLL to me. But I think that that's really important, and I think that that really kind of sets the tone. I think every patient is going to be different, and there are going to be certain things that you don't want to treat lab values. You want to treat the patient and really assess it at that. So any of the relative criteria, according to the TIL working group, should initiate supportive care measures and consider a delay. I think when you start to stack and add up some of these criteria, or you have absolute criteria, that's when you definitely want to delay and really start to consider a discontinuation unless they're easily reversible. So if more than 2 doses are held, you should discontinue. And to Becca's point, I think you're looking at the cardiovascular, the renal, the pulmonary, and those side effects kind of complications tend to complement each other and kind of pick up pace. One of the advantages, I think, in starting with the Q8 schedule is that you can delay up to 4 hours and still maintain a dosing schedule. So I think that that's an interesting strategy. And then, of course, in patients a little bit more frailer or somebody you're a little bit weary of, maybe just starting with the Q12 hour for the IL-2 anyway.
All right, and so now our patients have completed their IL-2 and they have fully recovered from all of the side effects, or if they had any remaining from the lymphodepleting chemotherapy, and they are ready to be discharged. So this can take prep. For us, we were seeing patients go home around 7 days after they get their TIL cells infused. So for our discharge criteria, mostly we want to make sure they're as close to baseline as they can be. So much of the toxicity is gone. Counts are, if not at an acceptable level for us, that would be an ANC of 500. Are they at least trending upwards and would be anticipated to be 500 the next day? AFib for 24 hours, off oxygen if that was suddenly required, and any adverse event resolved to less than grade 1.
So I will touch on some specifics of patient follow-up. And although there are no specific requirements noted in this commercial product information, there should be some institutional discussions on patient follow-up guidelines and definitely a clear plan for patient management, which again may look different for different institutions. For example, our patients admit under our BMT cellular therapy service, and upon discharge, we will schedule follow-up with their primary cell therapy physician within 1 week and schedule further follow-up from there. Our patients are encouraged to stay within close proximity of our treatment center and be overseen by the cell therapy team for the first 4 to 6 weeks or until the patient's first disease restaging assessment or based off patient condition. And then after that time point, the patient may return back to the care of their primary medical oncology team. So I think we can discuss a little bit how each of our centers do this follow-up. I know it varies a little bit center to center.
Yes, absolutely. So the first thing I want to mention is that my institution is very fortunate that our solid tumor cell therapy physician is also primarily a melanoma specialist. So switching back to their primary team is the same as staying with their cell therapy physician, which is wonderful. We see patients back within 48 hours of discharge. And then we see them twice a week for the first 2 weeks following discharge. After that, they can go back to their melanoma physician, whether that's in the community or our physician, and they would get labs about once a week until we rescan at 6 weeks. We were keeping them longer, and we just found that patients didn't need to see us as frequently for the most part. It was pretty rare, and we wanted to give them some time back.
And at Moffitt, we're still seeing patients approximately 3 weeks plus or minus a week. But again, I think this is kind of based off of our CAR-T practice. And so after that, patients are actually transitioned to their local provider for care after that.
Yeah, and we have solid tumor specialists working within the TCT team to help coordinate this care. But shortly after, I think about a month after, they go back to their primary service.
So I'll touch a little bit on disease monitoring considerations. Restaging scans can occur at varied intervals post-TIL and may depend on the location of the patient's disease and any possible symptomatic areas. There are still quite a few questions regarding specific timing of disease reassessment, but there's definitely still some ongoing research regarding disease response. I'll touch briefly on a study we found. The frequency of neoantigen-specific T-cell responses were measured in patients' peripheral blood, and this actually peaked between 3 and 9 months post-TIL, which suggests a subset of cells in the TIL product actually have the capacity for long-term survival and renewal. So I think we'll continue to see more research about disease response and especially the durability of this response. So I'll bring it open again. Does anyone else have any specifics on disease monitoring different than that at your institution?
A very similar practice.
Agreed, very similar.
Wow, you all managed to pack in all of that information in such a short period of time, and we are right at time in terms of questions and answers, but we have some ARS questions that we need to go through with the group. So the first question is, and then just FYI, there is a question in the Q&A in regards to dosing weight for cyclophosphamide. So if you guys want to type in a response while I read these ARS questions, that'll be great. So the first ARS question is, a potential TIL patient has been identified by the medical oncologist and scheduled to see the cell therapy physician and surgeon. Besides ensuring insurance approval and cell lab availability, what else does the nurse need to do? Is it A, confirm manufacturing slot availability, determining the patient's distance from the center, initiate bridging therapy, or D, notify pharmacy to educate the patient? Great. So the correct answer is A, making sure to confirm the manufacturing slot availability to make sure we coordinate that remaining timeline for manufacturing and bridging. So we'll go on to the next question. If it pops up. There we go. Which of the following of the interventions is least appropriate with lymphodepleting therapy? Is it adding fosaprepitant due to nausea and vomiting with previous therapy, manage neutropenia post-lymphodepletion with filgrastim, reduce fludarabine and cyclophosphamide due to creatinine clearance less than 50, or hydrate with mesna and encourage frequent bladder emptying? And remember, least appropriate. Okay, so it's a little bit, I figured I read this rather quickly and it's least appropriate. So nice job to the panelists for making this one tricky. The answer to this one is C, and the fact that cyclophosphamide does not require a dose reduction. It only would be a consideration for fludarabine. The next question is, which of the following should be considered when determining if a TIL patient is ready to be discharged from the hospital? A, there is no discharge as it's entirely outpatient. A and C counts approaching 300. Any toxicities resolved to CTCAE less than or equal to grade 2, or A, febrile for 4 to 8 hours. There's an F option that it didn't make it to ARS questions for those of you that are like all of the above. And that's exactly it. It is all of the above. So all of the following would be considered when a patient is looking to be discharged from the hospital. And then we have one final question. During IL-2 administration, if more than 2 doses are skipped, an additional dose may be given as a makeup dose on day +5. Is that true or false? Correct. It is false. So that's perfect. All right. Well, in closing out, because I know we are right at time, I just want to thank all of the panelists for such an important presentation today and very, very thorough in their presentation. Also, check the chat for a link to our attendee survey. We'd love your feedback. If you're a pharmacist and miss any of our sessions, the on-demand bundle, complete with all 3 videos, should appear on your dashboard in the next few days if it has not already. I appreciate you all and hope you have a great holiday. And thanks for having us today. Thanks, everyone.